This lecture will go over genitourinary alterations. As a whole, we're going to talk about enuresis, UTI, cryptorchidism, hypospadias and epispadias, hemolytic uremic syndrome, and Wilms tumor. This recording specifically will go over the differences in the genitourinary system with pediatrics, enuresis, and UTI. Please review A&P of the urinary system on your own if you need a little refresher. In a healthy infant, the kidneys operate at a functional level appropriate for the body size. However, function is reduced when the infant is under stress. By 6 to 12 months of age, kidney function is nearly that of an adult. In premature infants, the reabsorption of glucose, sodium, bicarb, and phosphate is reduced. The young infant's kidney cannot concentrate urine as efficiently as those of older children and adults because the loops of Henle are not yet long enough to reach the inner medulla where concentration and reabsorption occur. So what does that mean for infants, that they're not able to concentrate urine as efficiently? So when you think about concentrated urine, like if you were observing a urine sample and you have one that's a very light yellow and one that's a real dark yellow, which one would be the more concentrated urine? And it'd be the urine with the darker color, because the one that has a lighter color is more diluted, right? There's more water in there to dilute the color. With the darker sample, that's a more concentrated urine sample, meaning there's less water. So what it means for our patient is, let's say they're experiencing vomiting and dehydration, right? They're losing fluids. Their kidneys are less able to hold on to fluid, less able to concentrate that urine and keep water in their body system, which makes them more prone to dehydration. Young children have shorter urethras, which can predispose them to UTIs. Children usually achieve complete bladder control by approximately 4 to 5 years of age. Unlike adults, most children with acute renal failure regain normal function. Enuresis is defined as difficulty in maintaining bladder control. So we're talking about children that are wetting themselves. So let's go over some definitions. Nocturnal enuresis occurs at nighttime during sleep, whereas diurnal enuresis occurs during the day or in waking hours. Primary enuresis is defined as a child never having experienced a period of dryness, where secondary enuresis occurs when a 6 to 12-month period of dryness has preceded the onset of wetting. In regards to etiology, there is no single cause for enuresis. Several factors have been implicated. Physical factors include decreased bladder capacity in pediatric patients, underlying urinary tract abnormalities, neurologic alterations, obstruction, diabetes mellitus, and voiding dysfunction. Emotional factors related to increased stress can contribute to secondary enuresis, and they include family disruptions such as divorces, inappropriate pressure during toilet training, inadequate attention to voiding cues, and decreased self-esteem. Sexual abuse must be considered in a child with secondary enuresis. Primary nocturnal enuresis is common and occurs more frequently in boys and in children with a family history of bedwetting. Some children with diurnal or daytime enuresis can have diurnal daytime enuresis without nocturnal enuresis. Waiting until the last minute to void and not being able to access the bathroom quickly can be a factor in diurnal enuresis, but the main cause is an overactive bladder, a condition in which the child experiences bladder spasms or increased urgency. Primary enuresis often resolves spontaneously. Control of urination is related to the maturity of the central nervous system. By 5 years of age, most children are aware of bladder fullness and are able to voluntarily control voiding. Children usually achieve daytime urinary control first, with nighttime dryness occurring later. A child with secondary nocturnal enuresis or with problems of daytime control and complaints of dysuria, urgency, or frequency should be evaluated for other conditions. Bladder infections can give rise to such problems. Excessive calcium loss in the urine can irritate the bladder and cause painful urination, urgency, frequency, or wetting. Secondary enuresis accompanied by excessive thirst and weight loss may be indicative of the onset of diabetes mellitus. Children whose bladder are very sensitive to urine volume may have uninhibited bladder contractions. An anatomic abnormality in these cases is rare. Children with a continuing history of bedwetting are not able to sense bladder fullness and do not awaken to void. Because of physical maturation varies, nocturnal enuresis is not a matter for excessive concern unless the child is older than 6 and has markedly decreased self-esteem. Children with urgency, frequency, and inappropriate wetting during the day may be seen rushing to the bathroom or tightly crossing their legs. Often these children cannot sit still and exhibit a constant odor of urine. The diagnosis of enuresis is based on the history and clinical symptoms. Urinalysis and urine culture can rule out possible UTI because we talked about that the symptoms can be related to other disorders such as UTI or diabetes or pinworm infestation. So we want to, when we're assessing the patient and doing diagnostic evaluations, we want to rule those things out. So urinalysis can help rule out possible UTI. Measurements of urine-specific gravity and urine glucose are assessed for underlying diabetes. In addition, the child's urine should be checked for excessive calcium, and a pinworm evaluation should be done to exclude infestation. Bladder ultrasound and measures of urine flow and bladder capacity may be indicated. Children with UTI should have a workup for underlying structural abnormalities. Because enuresis can occur with constipation or onchoparesis, diagnosis includes a history of possible bowel dysfunction. Also assess the child's psychological state. It's important because social or emotional situations can contribute to enuresis, and enuresis can alter a child's self-esteem. Treatment of primary nocturnal enuresis often begins with general interventions, such as explaining theories underlying the problem in terms that the child can understand. Common sense approaches of limiting fluids after supper and voiding just before bedtime are encouraged. Diet modifications include avoiding sugar and caffeine intake after 4 p.m. because these substances act as bladder stimulants as well as diuretic. Also, the child can be trained to use imagery, thinking about what a full bladder feels like and picturing waking up and going to the bathroom. Reward systems assume that bedwetting is a voluntary behavior and have had varying results for children with primary nocturnal enuresis. The child can be given a roll of favorite stickers to mark the dry nights on a calendar. Behavioral conditioning with the use of alarms has been successful in older children with nocturnal enuresis. A pad placed on the bed or a device worn in the child's pajamas contains a moisture-sensitive alarm. When the child starts voiding, the alarm goes off and the child awakens. The alarm system must be used consistently, often for 3 to 6 months, depending on the severity and response. Adherence is a major factor to successful resolution. Medications include desmopressin and oxybutynin. Desmopressin has an antidiuretic effect, antidiuretic, antidiuresis, anti-urination. It's a tablet that can be taken at bedtime. Results improve when alarms and pharmacologic approaches are used concurrently. Voiding frequently to keep low volume of urine in the bladder can benefit children who are affected by uninhibited bladder contractions during the day. The use of an anticholinergic such as oxybutynin relaxes smooth muscles of the bladder and can be helpful for children with diurnal enuresis related to underlying bladder instability or small bladder capacity. Urinary tract infections, which are characterized by the presence of bacteria in the urine along with systemic signs of infection, are commonly seen in children. Infections can have long-term complications, including renal scarring with decreased renal function, high blood pressure, and rarely end-stage renal disease. UTIs, except in newborn infants, are caused by bacteria ascending from the outside of the urethra into the bladder, and from there into the upper urinary tract. Bacteria in the blood, which seeds from the kidney, can cause UTIs in newborn infants. Fecal bacteria causes most UTIs, with E. coli being the most common. Conditions that can predispose a child or infant to UTI include urinary tract obstructions or strictures or narrowing of the urinary system that prevents urine from flowing as it should. Voiding dysfunction that results in urinary stasis, conditions contributing to incomplete bladder emptying. So anytime that the urine's allowed to be just sit when it should be moving out of the body, that's considered stasis, and that sort of presents a nice breeding ground for bacteria. So narrowing or strictures or obstruction is bad. Stasis is bad. Just the shorter urethras, especially in young girls, predisposes them to a higher infection rate. Any individual with susceptibility to infection Reflux, we're going to talk about the vesicoureteral reflux that can contribute. We'll talk about that in a minute. UTIs in toddler age girls are more frequent during toilet training, most likely the result of urinary retention or incomplete bladder emptying, again leading to that urinary stasis. And then finally, sexually active adolescent girls are an increased risk for UTIs. Please review box 44.1 for manifestations of UTIs in infants and children. So it's important to know the difference. There's some differences in what you're going to see just because of the development of the child, right, in terms of urinary tract infection. So you want to know these differences, the differences of what you're looking for in an infant versus a child. Then you move on to children with pyelonephritis. So pyelonephritis should be a term that you're familiar with, which would indicate that the infection has moved up into the kidney, so kidney infection. Some symptoms for children with uncomplicated UTIs plus, so same sort of UTI symptoms plus these. So the big thing is the back pain, flank pain, high fevers with chills, nausea, vomiting. The appears very ill. So again, once that infection moves up to the kidney, the patient's going to become pretty severely sick. Pyelonephritis is more frequently seen in children with vesicoureteral reflux, but can occur in its absence. Infants and young children less than 24 months are presumed to have pyelonephritis if they present with a febrile UTI. Scarring as an inflammatory consequence of pyelonephritis is more frequently seen in infants younger than 1 and is a significant cause of hypertension in childhood. Next, we're going to talk about hydronephrosis. Obstruction at the ureteropelvic junction or other parts of the ureter cause dilation of the kidney. As the renal dilation increases, the risk for renal parenchyma damage and decreased renal function increases. So hydronephrosis, sometimes you hear lay people refer to it as water on the kidney, but basically what it is a backup of that urine. So there's more urine in the kidney than it should be because it's not draining properly. So looking at this picture here, in vesicoureteral reflux, 2 mechanisms contribute to UTI. Bacteria in the urine can be carried up into the kidney, causing pyelonephritis and renal damage with scarring. Also, when urine reflux in the lower ureter occurs, urine can return to the bladder, leaving residual urine that becomes a medium for bacterial growth. So normally what happens is there's a valve here, right? Here's your normal kidney, ureter, and bladder. So normally there's a valve here. So when the bladder fills up, the urine isn't going back up towards the kidney. Or when the patient urinates, that valve closes. So the urine only can be excreted or stay in the bladder, won't go back up towards the kidney. If that valve isn't working correctly, that's when reflux up to the kidney can occur. And you can see it can cause dilation of the ureter itself and also cause the hydronephrosis with that extra fluid in the kidney itself. The other thing it talked about is stasis. So if I'm urinating and urine's coming back up here, and then I've urinated out and I stop, and then it comes back into the bladder, that means urine that was supposed to be excreted is still in my bladder, right? And we talked about that stasis puts the patient at increased risk for UTIs. Diagnosis would be made through a urinalysis, which would show nitrites and or leukocyte esterase. May also show white blood cells and possibly red blood cells also. First morning urine specimen is most accurate for urinalysis. Obtaining a sterile urine sample can be difficult. A child who can void on demand can provide a midstream clean catch urine sample. Infants and children who are not toilet trained, a sterile pediatric urine collection bag can be attached to the perineum and collect a urine specimen. Collecting urine, this method is less invasive, but is not as accurate for obtaining a culture as other methods. You can also do a straight cath in order to get a nice sterile sample. Treatment of UTIs would be with antibiotics. Please review the purple nursing care box for the child with urinary tract infection on your own. And please also review the box for how to manage and prevent urinary tractions. This contains excellent teaching points for parents. So here's a little slide about it also, but please review those on your own.